we will be official. Okay, so we are officially recording. This is going to be the NUR 188 comprehensive final exam review prep session. I think what we're going to do is just kind of go through unit by unit. I just want to kind of emphasize and hit some key points. Certainly while I'm on the different units, if you have questions related to that specific unit, that would be a great time to put them in the chat box. But certainly you can put them in anytime and I'll make sure everything gets addressed, you know, by the time we're finished here. So we'll go ahead and start right at the beginning with unit 1. But before we go there, I just want to emphasize to you, you know, as a nurse generalist, and, you know, it's kind of ironic we're having this session today. It's the beginning of Nurses Week. Today is National Nurses Day. Actually, National Student Nurses Day is Friday, which is when you're taking your exam. So that's kind of ironic too. But when we talk about being a nurse and thinking about graduating from nursing school and being essentially what we call a nurse generalist to start, you need to think about things related to just basic safe care, because it all really goes back to that basic foundations. Yes, you can be working in the ICU and have all these different drips and ventilators and everything, but if you're not going back to the basics, your safety and infection control, you're repositioning your patient, your nutrition, you're promoting oxygenation and circulation, you know, your patient's not going to survive. So as you're approaching today and as you're approaching the rest of the week in the final, I really want you to think about, you know, that basic safe nursing care. What do you need to know to take care of these patients? And, you know, it's not even as much disease specific as it is those general concepts. And we talked about this in relation to Unit 5. It didn't matter what respiratory disorder we were talking about, promoting airway clearance is promoting airway clearance. And, you know, trying to improve gas exchange is going to be a lot of the same interventions regardless of what the diagnosis is. So as you're looking towards this final exam, that's how I really want you to be approaching it, thinking about that basic safe care. So, all right, I made some notes here because I just want to make sure I'm hitting everything. All right, so let's start with Unit 1, way back in January when we were talking about Unit 1. And that's your sensory unit. So it focused on the skin, the eyes, and the ears and hearing. So let's kind of just go through those one by one. So thinking about skin and tegumentary, it goes back to foundations. It goes back to skin assessment. What you're looking at, that it's intact, what's the generalized color, what's the moisture, okay? What's the consistency? Are there lesions there? If so, what do they look like? And not necessarily getting down to the nitty gritty of what's a vesicle, what's a papule, what's a macule, but think about it from a basic skin assessment perspective. Being able to look and see, okay, that's normal, that's an expected finding, versus this looks a little suspicious. I think it needs to be evaluated, you know, because we're thinking, you know, skin cancer, or even things such as psoriasis and stuff like that. Again, you're recognizing that it's abnormal. So when we start with skin, it really starts with assessment and really being able to identify findings that would require, you know, provider evaluation pretty rapidly, or intervention. You know, certainly if I have a patient that falls and they have a skin tear, it's bleeding, I need to be able to address that, you know, cleaning the wound real good, putting that dressing on because we want that healing to take place. You also think about interventions that promote skin integrity. You know, so we go back to the basics, the turning, the repositioning, maintaining adequate hydration, making sure your patient's skin, they're not sitting in moisture. Okay, whether it's diaphoresis because they're sweating, they have a fever, maybe it's low blood sugar, or incontinence, urinary bowel incontinence. You know, you want to make sure you're promoting, you know, good skin integrity, you know, repositioning, just basic daily hygiene and cleaning the skin, making sure you're applying lotion for moisturizers. But again, you know, keep in mind that when you put moisturizer on, you definitely want to make sure that you're adequately drying. You don't want to put lotion like in between the toes or really even in between like the skin folds, because that moisture is going to stay in there and then it can grow bacteria. Okay, great. We have a question. ATI indicated that powder should not be used to keep moist areas dry when a patient's immobile, but I've seen it used regularly in clinical settings. So yeah, so there's a couple things with powder. It depends on how you're using it and where you're using it. There was a recent lawsuit that was actually found against the pharmaceutical company about powder being linked to different types of cancers. That particular case was related to powders being used down in the genital area. And there was a question of whether some of that powder intentionally or unintentionally essentially became internal. Okay, so that's something you always need to consider. So you need to make sure if you're using powder, and I will tell you, it kind of goes back and forth. The newer recommendations are saying not use it. I've seen it used appropriately. Certainly you need to use it sparingly. You need to make sure that it's dry, and you need to make sure that you're not using it close to orifices where it could get inside the body. Okay. It is very helpful for patients that have like large skin folds and there's moisture in between those. But I do want to emphasize that powder is not a substitution for hygiene, for washing and patting dry. And, you know, like I said, we've used the tip before about the hair dryer on a cool setting. That is very helpful for obese patients or patients with skin folds that after you've washed, you've patted it dry. Using that hair dryer on the cool setting can be very helpful in drying that skin. If there's moisture that's left on that skin and, you know, the skin folds kind of close, you have moisture in a dark area, which just predisposes to the growth of fungus and bacteria. And the other thing you need to think about is not just, you know, moisture from bathing, but also moisture from sweating. Okay. You know, you often kind of think, well, older adults may not do as much activity. Well, that's fine. But throughout the day, when you have skin rubbing together or folds that are touching there, it definitely predisposes them to bacterial growth there. So they should be bathing. Even though long-term care residents, we don't shower them every day, they should be getting a bath every day in the sense that we're washing between those skin folds and drying very well. Also, in relation to the lotion, again, with the lotion, you do want to apply that. It's actually best applied right after bathing because you want to kind of lock some of that moisture into the skin. What you do want to think about though is when you're putting the lotion on, again, you guys know diabetics never between the toes, but also when you put that lotion on, you really do want to kind of let it air dry before you're putting socks on and before you're putting clothing on. You know, you got to look at that too. Again, if your patient is moist a lot, they're incontinent, they require perineal care, you're going to be cleaning this very often. If they sweat a lot, that moisture, they may need to be bathed a little bit more often, sometimes even twice a day. And that doesn't mean every place all over the body, but certainly in areas where you have those skin folds that are coming together. So great question. Other things in relation to promoting skin integrity. I'm not quite sure where I left off here. Hydration, you know, very important. If they are dehydrated or overhydrated, you think about cellulitis patients whose legs are so edematous that they're weeping, that actually puts them at risk for the skin breaking down, creating a portal of entry and making everything worse. So hydration is important. Thinking about nutrition, making sure they have adequate calories and they have adequate protein intake. You know, it all goes back to that. If your body doesn't have the building blocks to create the substances needed for cellular function and skin growth, you know, they're going to have problems. And that's why we see a lot of skin issues in older adults, because we have like all of these different factors kind of coming together. You know, you have the incontinence, you have the decreased mobility, their nutritional intake can be poor. So when you look at long-term care facilities, that's why you tend to see a lot of skin issues. You know, despite doing our nursing interventions, you got to be very meticulous and stay on top of that. So repositioning patients, really assessing that skin, looking for risk factors, looking for potential skin breakdown. And just kind of a reminder, when you think about skin breakdown, stage one, just to reemphasize this, stage one is a reddened area. It is still intact, but it's red. When I go to press on it, a stage 1 is non-blanchable, meaning when I go to press on it, the area around where I'm pressing will not turn white, okay? So it's very important to kind of differentiate that. Ideally, we want to catch it before it becomes a stage 1. We want to be preventive. But when we have a stage 1, that skin is still intact, but if we're not doing something about it, it is going to open very quickly. And stage 2, now you have that opening in the skin. Okay, let's see. So also think about things related to skin, and this kind of relates to promoting skin integrity, but like health promotion. You know, we talked about the proper use of sunscreen. You know, we talked about, you know, tanning coffins are just not such a good thing. But then going back to those interventions we talked about promoting skin integrity. Switching to the eyes. Okay, there were a lot of different visual disorders, okay? All right, that's great. So if you have a basic understanding of the patho, then you kind of get what's going on with the patient. But when you think about this as a nurse generalist, whether I'm working with someone who's, you know, legally blind or who has macular degeneration or cataracts or glaucoma, they all have decreased visual acuity. So when you think about that, how do you work with those patients, okay? What do you do to keep them safe? Okay, because safety is a big thing. And what do you do to promote their independence to keep them functioning as long as possible? So, you know, thinking about safety, go back to your basic fall precautions, you know, making sure your path to the bathroom is clear. If they have decreased vision, how would they know that you're in the room? So think about, go back to fundamentals, knocking on the door and introducing yourself. Hi, my name is so-and-so. I'm a student nurse from Penn College. I'm here too. So making sure you're introducing yourself. You know, for decreased vision, for them to be able to function, think about meal times. You know, think about the basics of the plate and how it can be a clock orientation facing the patient. So being able to describe what's on the plate. Certainly making sure that they have their call bell. Usually when you have somebody with diminished vision, if their hearing is still intact, their other senses tend to be a little bit more heightened. So keep in mind, you're still going to talk to them as if they could see. Don't belittle them, don't baby them. We want to promote that independence. You know, if they're independent at home, we want to promote that as much as possible. Now, do keep in mind, they may be independent at home and they come into the hospital. We have a totally different furniture layout. You know, we have a totally different routine. So you want to make sure you're explaining these things, but as much as possible, you want to promote independence. So think about things such as adequate lighting. You know, if they like to read and they have some trouble, think about the large print books, the audio books. Again, it's all, when you think about these chronic issues, it's all about maximizing their function and keeping them safe. That's really what it all boils down to. Other things related to eye, we talked a little bit about eye surgery, and we focused a lot on cataract surgery, but this also applies to things like detached retina and that. So thinking about your 7 areas of discharge teaching, you know, what should they expect? Activity-wise, what can they do? Anytime a person has eye surgery, we're going to limit their activity because we don't want to raise their blood pressure, because that pressure will then raise their intraocular pressure. Thinking about post-op, they should not be having pain. These are not painful things, but activity, positioning is very important. They're going to have drops. Okay, so one of the key things when you're talking about an eye patient, whether they're a surgical patient or, you know, they have a disorder where they're just using eye drops to, you know, maintain their pressure, that sort of thing, they have to know how to put those drops in. You as the nurse need to know basic foundations, basic fundamentals. How do I put those eye drops in? Okay, I'm telling you, I keep saying this over and over again, but it goes back to the basics. It goes back to foundations. You know, for your hearing, for your ears. You know, we talked about some different disorders, but again, it goes to the same thing we talked about with the eyes. You know, with hearing, we want to obviously maximize their hearing. We want to maximize communication. So regardless of whether they have an inner ear infection or, you know, they have, you know, hearing loss, or they have Meniere's, which also results in hearing loss. You know, it's all about how do you interact with somebody who is, you know, hearing impaired. You know, what are the things that you do? You know, obviously tamping down on the background noise, facing them directly, speaking not extremely slowly, but you want to speak clearly and you want to enunciate your words. Think about the nonverbals that help them pick up on things. So it's things like that that we look at promoting maximum function. Of course, we have things like hearing aids. So think about the basics with that. They're very expensive. So you get into the hospital, you want to know who has the hearing aids, where are they, what container do we have them in that they take them out at night. Think about if you're doing a tympanic temperature, okay? And you definitely want to know if your patient has hearing aids. Because if you don't know, some of them are very, very tiny. And if it's already in there and you go in there to do a tympanic temp, you can actually push it farther in and puncture that tympanic membrane. So definitely not something, you know, we want to do. You know, we didn't talk a whole lot about ear meds in 188, but that was actually part of your foundational knowledge from 186. So when you have a patient who has ear medications, usually it's going to be ear drops, whether it's, you know, an antibiotic drop, or probably the most common one that we use, particularly in the older adult population, are your earwax removal drops. We call them Debrox. But it's really important that, you know how to put those eardrops in, because again, that works to management of patients with chronic ear issues. Okay, so that kind of hits a lot with Unit 1. I'll pause for a minute, see, does anybody have questions related to Unit 1 at all that they want to pop in the chat box, and we can kind of address that. If you have one later on that pops up, you can stick it in there too, and I'll still answer it. It's not a problem, but just trying to keep everybody organized here. So I don't see others popping in, so I'm going to kind of, oh, here we go. Can you go over what nail deficiencies correspond to different nail angles? Okay, so that one, when you're looking at the nail angles, clubbing in particular, that indicates a patient has been hypoxic for a long period of time. So this would be in your, I would probably say moderate to severe COPD patients. You're not going to see this as much in your mild COPD, at least not initially, but as the disease progresses, you're going to see a problem with that. So the clubbing, very important to kind of note that that is going to be more related to your long-term hypoxia. The spoon-shaped and the Bose nails, those are cool things. We talk about what's the need to know, what's the nice to know, what's the nuts to know. Those things are probably not as important for you to focus on. Certainly the color of the nail bed, are they nice and pink? Because that's going to indicate adequate circulation. Do they appear pale? Which can indicate that your patient's anemic. It can also indicate that you have poor circulation to that area. Are they yellowed in the sense that they have like fungal growth in there? So those are kind of the big things that you would be looking at. Okay, main differences between basal cell, squamous cell, and malignant melanoma. Okay, well, things that are in common, they're all cancers. Basal cell carcinoma tends to be very localized, and it will grow like big, like it'll grow out, but it doesn't necessarily get as deep into the tissue as your squamous cell and of course your malignant melanoma. So, I mean, if I was to have one of those, I would prefer basal cell carcinoma. Squamous cell carcinoma, it almost kind of looks like a scaly, scabby, redden type area, but that one does start going down deeper into the tissues. And then of course the malignant melanoma, that's going to affect the melanocytes down in the skin. That's the one that's going to be the most deadly. Squamous cell carcinoma will spread, but it generally spreads like regionally, whereas malignant melanoma, you often see distal spread with that. And that's why that one tends to be the most dangerous, because a lot of times by the time it's diagnosed, it has spread to other places. Going back to the basics, going back to skin assessment, and we talked about, looking at the color, looking at lesions. Always remember your A, B, C, D, E. So asymmetry, so if I have a lesion, does it look symmetrical? Looking at the borders, is the border regular, circular, round, or is it jagged? Is it irregular? Looking at the color. Is the color uniform? Is it very light? Is it very dark? Is it speckled? Does it have multicolors? Certainly diameter, if it's something that's beyond what we typically say 6 millimeters, which is about the width of a pencil eraser at the end of a pencil. And then certainly the E piece, the evolving. If you're noticing or your patient's noticing that a lesion is changing, that is going to be a big red flag that they need to get that evaluated. Does it mean it's cancer? No, it doesn't mean that. But it's something that tells us something's going on here. It needs to be more evaluated. Perhaps they want to do a biopsy of it just to make sure. If it's getting to be bothersome to the patient, they can also actually do a removal, particularly if it's something small like a nevus or a skin tag, something like that. So, okay, I'm going to go ahead and move on to Unit 2. If you have other Unit 1 questions, you can pop them up there and I'll make sure I get to them. But Unit 2 focused on genitourinary. So again, we're going to go back to foundations. So think about the basic things related to urinary elimination that are going to impact your patient. So number 1 is going to be hydration. Okay, very, very important. You want to keep your patient hydrated, not only to promote skin health and everything else, but it also helps protect your patient's kidneys. Okay, we want to make sure those kidneys are well flushed because they are exposed to, substances every single day that they're filtering the blood and they're excreting stuff from the body. So it's very important to maintain kidney health. So hydration is kind of going to be the first thing you want to look at. The other thing we look at is promoting elimination. So it seems like common sense because it is. Okay, how do females pee? We sit on the toilet. So if you can put your patient in a sitting position, female, that's going to help promote urinary elimination versus trying to put them on a bedpan. For males, the majority of our males are going to stand up to urinate. So if you want to really help somebody with enlarged prostate empty their bladder, they're going to do a much better job if they stand up to urinate versus try to sit down to urinate. Okay, so those basic things, just kind of thinking about that. Other things with promoting urinary health. We think about stones, and yes, there are some modifications that you can make for specific stones, but the big thing that you can do to help prevent future kidney stones relates to hydration. Making sure that your patient is hydrated. We don't want those substances, those little solutes in there to come together to be able to form a stone. So hydration is a big thing there. Also you think about things such as, urinary assessment, asking them about their urinary patterns. Are they having dysuria? Are they experiencing burning? Are they voiding small amounts? Does their urine smell? So things that might indicate that there's a problem, particularly with infection. Okay. Other things that were big with urinary, think about the stuff that we talked about in relation to procedures. So we talked about urinary catheters. That those are a portal of entry for infection. Caudies are the #1 healthcare associated infection in the United States. So making sure if you're catheterizing somebody in a facility, you're using sterile technique. A little bit different at home. They use clean technique at home because the germs that they're exposed to are the germs that's part of their normal flora. But also just thinking about how you manage a catheter, the basics, keeping the bag below the level of the bladder, making sure you're maintaining a closed system. We want to get that catheter out as quickly as possible. We also talked about continuous bladder irrigation. So that was something that's pretty important. With that 3-way irrigation, remember the basics. What goes in must come out. So if that fluid, that irrigant that's flowing in is not coming out, that's going to stay in there. It's going to distend the bladder and you're eventually going to get to a bladder rupture. So thinking about a CBI, what are your priority pieces with being a nurse? Making sure that they have outflow of that irrigant, that they are having urine output so that that catheter is free flowing. What does the urine itself look like? Are there any clots that would make it more likely that it would clot off and it would become obstructed? So that CBI is really important. Remember, we talked about delegation in relation to that. Really, it should be an RN taking care of that patient. LPNs who have experience in that area, I'd be okay with them helping with that. But, you know, again, that patient really needs to be overall managed by the RN, and your aide can help empty out the catheter bag and record what they emptied. But in relation to calculating that INO and trending it and evaluating what's happening with the patient in relation to their urine output and the CBI, that's going to be your RN scope of practice. Okay, so just kind of thinking about it from that perspective. Let's see, I'm trying to think what else kind of goes along with that. What else did we talk about? We did talk about, prostate cancer and patients going home with a catheter. So think about home management, home use of that catheter, being able to switch from that large bag, the overnight bag, to the leg bag, and doing so in a way that, you know, maintains aseptic technique, because anytime you're disconnecting a closed system, you have the potential to introduce bacteria. Again, they're going to be doing that in their home environment, so we do need to teach them the proper way to do that. But it's a little bit different than having somebody switch back and forth from a leg bag to a, you know, large bag frequently in a facility type setting. Okay. Can we do a calculation example for CBI, or can you post one? I don't think that's really necessary if you know what I'm talking about, but basically just a brief review of that. You know, you take what was out, you know, what has come out, what we have emptied from the Foley, okay, and kind of total that up. And then you need to account for the irrigant that went in. So just a basic example, if I emptied out 1,000 milliliters from the catheter over my shift, and I look at my bag and I've had 300 of the irrigation infuse in, okay, well, I had 1,000 out, but 300 of that had to be the irrigant. So really it would only be 700 milliliters of true urine output. Reviewing which kind of stones are caused by what nutrition. So your big thing is going to be like your oxalate stones, is like your purines and your high proteins. So people that have those types of stones, your oxalate stones, those are the ones that we really want to watch their total protein. Not that we want to go very low, but typically we say 60 grams a day should be the max for them. But hydration is going to be the key. Your uric acid stones, those are the ones that if it's really bad with your patient, we do hydration, but they may also be treated with allopurinol because patients that have high uric acid levels, not only are they at high risk for stones, they're also at high risk for gout too. So you'll see things both ways there. Your most common stones that you're going to see are your calcium oxalate stones. The things that I like to emphasize with that is we no longer advise that they lower their calcium intake. And the reason, that's something we used to advise years ago. We don't do that anymore because it actually predisposes them to osteoporosis. So if it's a calcium-based stone, we're going to push the hydration. Where it gets to be a problem, high calcium levels, if they have high calcium levels in the blood, you have to think about the relation of the solute, the calcium, to the plasma. So if I have a lot of calcium packed into plasma, it's kind of very close together and it's more likely to form a stone, which is why hydration is so important with that. So I think that kind of hits the big ones. Yeah, I mean, really your biggest thing when you think about your purines, your proteins, certainly things like sardines, your liver, things that have high levels of protein, particularly your animal proteins, are things that you want to kind of watch. Rhubarb as well. I mean, I know that's not a meat, but rhubarb as well is something that we kind of really avoid with that. But your biggest thing with the stones, your recommendations are always going to be based on the stone analysis, but the biggest thing that you're going to tell patients that apply to any type of stone is going to be the hydration. No, you don't need to know how to read a urine or stone analysis. Basically, when you look at that, you're looking at the stone and you're looking to see, okay, what type of stone was it? And then whatever that answer is, whatever the response is, that's where you would tailor your teaching to the patient. So if it was something, you know, related to an oxalate stone, you could very much tailor that. I wouldn't tell, you know, somebody with a uric acid stone the same dietary things I would tell somebody with, you know, your oxalate stone. So in kind of thinking about that, you know, as a nurse generalist, You want to understand the piece about hydration, and you want to understand there are some different dietary modifications, but that's something that would be very specific. And when you would use, like in a clinic setting or in a hospital setting, you would use your patient education software where they print out that discharge teaching. You would be very specific to the type of stone once we, have looked at that. So good questions. I'm trying to think, anything else? Unit 2, throw some questions up there if you have them. Going back and thinking about the medications, okay, because I know I've gotten some questions in relation to pharm. So thinking about medications for urinary tract infections, we kind of do a two-pronged thing. We treat them with the antibiotics, which we've talked about antibiotics all semester. You got to get the sample, the culture sample before you start the antibiotic. You don't have to wait for the results, but you have to at least get the sample. Thinking about the general principles of antimicrobials, making sure they're taking their medications on time and finishing the entire prescription. Again, promoting the hydration, 1, to flush the infection out, but 2, to help protect the kidneys. Do keep in mind that your antibiotics can cause some photosensitivity. So your patient might be a little bit more sensitive to light with their skin developing a sunburn if they're out in the sun. The other thing to kind of keep in mind with your antibiotics too is they kill off the good flora. So you can see an increase in like your fungal infections. Babies, we often see thrush in the mouth. Females, we tend to see vaginal yeast infections, so that's something to keep in mind. And then of course they also do interfere with oral contraceptives, so depending on who your patient is, I don't think your 85-year-old female really has to worry about that, but depending on who your patient is, that's a pretty big priority point. On the flip side, we also have the analgesia part of the UTI, so we tend to use the pyridium, which can turn your patient's urine orange, but it's that urinary analgesic, and it is very, very effective. We can also use your non-opioid analgesics, things like acetaminophen, ibuprofen. Again, I probably would not use ibuprofen if it is an upper kidney infection, if we're talking pyelonephritis where I now have the kidney involved. But we could use those non-opioid things to manage pain, also to manage fever, although that's a little controversial. Remember your immune system. The reason your body runs a fever when there's an infection is it's trying to slow down the pathogen. Bacteria, viruses, fungi, all of that, they do not replicate as easily in a warm environment. So you want to kind of be cautious in, do I really need to treat this fever or do I not? So generally with your UTI, treating with the antibiotics, we're treating the cause of the problem. We use the pyridium, treating the symptoms there, plus the hydration, that can be very beneficial. Medication wise for your kidney stones, keep in mind, very painful. So we're probably talking opioid analgesics here. Think about safety. Your opioids are going to affect your respiratory drive. So making sure you're adequately assessing your patient's respiratory status and level of consciousness prior to giving that is going to be important. These also tend to cause nausea and vomiting. So you'll see antiemetics used such as ondansetron, Zofran. Sometimes we'll see the promethazine, which is also known as Phenergan. Sometimes you'll see that used, but again, our go-to is really going to be your ondansetron with that. Hydration is also important in relation to stones. Here we're trying to flush that stone out. Medications related to BPH. Okay, so remember we have those 2 main classes. The one is going to be your testosterone blocker, okay, your finasteride. That's going to block your testosterone, and in that it should shrink the size of the prostate. That's the one, because it's blocking testosterone. We're concerned about females of childbearing age handling it without gloves, so it has that special precaution. Your other ones, your tamsulosin, remember that is going to relax the smooth muscle of the prostate to allow for the urine to flow out a little bit easier. Now remember, it relaxes smooth muscle. You have smooth muscle way more places than just the prostate, okay? So it's going to relax all of that smooth muscle. So think about your blood vessels. It's going to relax them. It's going to cause vasodilation. So it's going to drop that blood pressure. So again, think about orthostatic hypotension and how we would manage that. Okay. Let's see, other medications. We talked a little bit about the erectile dysfunction medications. Again, the bigger thing with that before you go to the meds is thinking about erectile dysfunction. A lot of times it can be related to medications, specifically beta blockers. It can also be related to underlying disease processes. Diabetes and hypertension come to mind. So when you have a patient who has ED, the thing that we really want to focus on is looking at potential causes of the ED before we go immediately to medications. The other thing to keep in mind is if the patient takes nitrates, if they're on nitroglycerin, patches, sublingual tablets, anything like that, that is an absolute contraindication to any of your erectile dysfunction meds. They obviously have other options there, but from a medication standpoint, that's a complete contraindication. Do we need to know the difference between Indiana pouch versus ileoconduit? So the big difference between them, again, thinking generally, the Indiana pouch is a continent urinary diversion. So it has like a little stoma, but it has, when they create it surgically, it has like a little pucker valve in it. So what the Indiana pouch is, it has that stoma, but essentially inside is a reservoir for the urine, and it's not going to drain out on its own. Unless it gets extremely overfilled, but it's not going to drain out on its own. It requires the patient to insert a silicone catheter through the stoma, through the pucker valve, and drain the urine out. Okay, so it's considered a continent diversion. Versus the ileoconduit, this is your basic urostomy. So you have a stoma coming out, you use the pouching device over top of it, and the urine drains into the pouch. You empty the pouch just like you would a colostomy or an ileostomy, except it's draining urine. So looking at the difference, the big difference that you want to understand is the continent versus the incontinent. Obviously, both of them are going to cause some body image disturbance. Both of them have things that the patient needs to adapt to and learn, you know, whether it's how to care for the ostomy or it's how to drain the Indiana patch. You know, they need to know how to do that, but it's those main concepts. Yes, so urine will have mucus in it in the ileoconduit. So that is a good important point to kind of think about, because, you know, usually we look at urine, oh, it's cloudy, there's stuff floating in it. The first thing you think about is infection, okay? And true, because that is the case a lot of times. Somebody who has an ileoconduit, though, because of how it's constructed, there is always going to be bacteria and mucus shreds in that urine, because we are using a portion of the bowel to collect that urine and then bring it out to the outside of the body. So if you would run, not that we would, but if you would run a urine culture on, you know, somebody that has an ileoconduit, you're going to definitely get bacterial growth. But then we start looking at, you know, what's normal flora, you know, and do they have other symptoms systemically of infection? Okay, so very good questions, very good questions. Any more for Unit 2? Okay, well, if you do, just pop them up there. I'm going to kind of move on to Unit 3, which is where we focused on musculoskeletal and the hematology. So let's kind of break that down a little bit. Musculoskeletal. Okay, go back to foundations, go back to the basics. I feel like a broken record, I keep saying that. But it all goes back to maximizing function and keeping your patients safe. So if you go back to foundations, think about assistive devices, okay, with basic ambulation, but also, you know, post-surgery. You know, if your patient has had a hip replacement, your patient has had a knee replacement, they're not going to be walking without an assistive device. Also, speaking of the hips, remembering the hip precautions, you know, that they can't bend over more than 90 degrees. They need the raised toilet seat. They cannot sit low in the chairs. They're going to need grabbers. Okay, they need help putting their socks on, because they cannot bend over to put those socks on, because you'll go beyond that 90 degrees and you risk the dislocation of that hip implant. Okay, so those are things to kind of think about in relation to musculoskeletal. The other thing, go back to assessment. How do you assess somebody's musculoskeletal status? first of all, you're looking at their walking, their posture, their gait, but also think about, we talked about neurovascular checks, looking for, do they have movement, sensation, and circulation in that limb? If you're doing a general musculoskeletal assessment, really in all the limbs, but if we're talking about a patient who has had surgery or who has had an injury to a particular limb or limbs, making sure you're evaluating that movement, sensation, and circulation. And, we talked a lot about compartment syndrome and how dangerous that can be. So what is compartment syndrome, and how would you identify that based upon findings in that neurovascular assessment? And then as the nurse, what would you do? That's not something that, I as the nurse can independently deal with unless that compartment syndrome is being caused by like a dressing. A dressing is very tight. I can loosen the dressing. I'm still going to call the surgeon. I'm still going to call the provider. But in that case, there's something I can do about it. But if it's a cast, that's already on there, I can't take the cast off. That's not in my scope of practice in that particular setting. So that's going to require immediate notification of the provider. So, I generally tell you, usually notify the provider is not the correct answer. In a case like that, you have compartment syndrome, you got a cast on it. There's nothing more I can do as the RN. They require provider intervention. So that's always important to kind of, think about that way. Cast care in relation to the assessment, but also, just thinking about your casts and your splints. In general, we don't like to get those wet. I always think, every time I think about a cast, I think about my peds rotation in nursing school, and that little kid who had a cast on his leg, and I guess he was itching down in there. So he done stuck a crayon in there, was trying to scratch on his skin, and he dropped the crayon. It actually went into the cast. And, of course it's a kid. He didn't want to get in trouble. He didn't tell anybody. So I think it was a couple days later, they were actually ready to get the cast taken off. And that's when I was there for my clinical rotation. And so they cut the cast off, which was kind of cool by itself. They bivalve the cast and take it off. And all of a sudden we saw this purple streak. And, the first thing you think about is, oh my God, it's on his skin. What happened with the skin? Here it was, his purple crayon that, fell in there. So, long story short, they should not be sticking stuff down inside their cast. That's not a good thing, not a good thing to do. In general, if they're really, really itchy, a lot of times it tends to be at the top part of the cast or the bottom where it's like, the edge of the cast and it's touching the skin. So sometimes we can use cotton to pad that. If they're really, really itchy, we can contact the provider and we can do, maybe an antihistamine, something like, Benadryl, just to kind of take the edge off of that. But bottom line, you do not want them shoving stuff down inside their cast. That's just not a good thing. So other things we talked about in musculoskeletal, thinking about osteoporosis, and even arthritis in a way, but thinking about how do we help manage those things health promotion wise. So obviously achieving a desirable weight, somebody who's heavy and overweight is going to be at higher risk for your osteoarthritis. So weight management is really important. For osteoporosis, we talk about increasing intake of calcium, increasing intake of vitamin D, weight-bearing exercise, getting them up and walking is going to be so important to try to prevent osteoporosis in these patients. So thinking about that health promotion piece of it. That kind of ties into anemia as well. So thinking about anemia, sometimes it's a dietary thing, and they need to increase the amount of iron in their diet, or perhaps folate or vitamin B12. In some cases, vitamin B12 deficiency, your pernicious anemia, relates to not having enough intrinsic factor. So if you remember back to your A&P, the intrinsic factor is produced in the stomach. So if you have a patient who's had stomach surgery, or they have some sort of stomach dysfunction, maybe they have multiple ulcers, gastritis, that sort of thing, they can become deficient in vitamin B12, even if they're taking in tons of it, just because they don't have the intrinsic factor to be able to absorb it. So for those patients who require supplements, you either need to use the nasal B12 or the B12 injections. But in general, when you have a patient who's anemic, first things first, let's support their functioning. If they're severely anemic, they may require oxygen supplementation and transfusion. If this is more of a chronic anemia that's not severely low, we can start with dietary modifications. We may start with supplements, you know, your oral iron supplements. If it's down a little bit lower that the oral isn't going to be enough, then we're looking at IM or IV. Remember, the key safety thing with those is going to be to administer that test dose. PO iron is used most frequently. When we're giving iron, if you can combine it with vitamin C, that's going to enhance the absorption of iron. So that's a good thing. You also always want to space iron away from dairy products because it's just going to bind to it and it's not going to get absorbed. So those are kind of some things to think about with your anemia. Other questions on Unit 3? I kind of hit the big key points that I had on my little notes here, but you know, other things that are important in relation to osteoarthritis, making sure your patient is staying active, that they're using good lifting practices. You guys definitely got that when you were at clinical. If you have a larger patient, a minimum of 2, and really if you have 3 to 4 people to be able to move a patient, it's much quicker, it's safer for the staff, it's safer for the patient. So thinking about good practices, you know, not bending over at the waist, bending your knees, you know, just lifting appropriately, and, you know, raising the bed. I remember how many of you did I check off in fundamentals and I'm like, raise your bed. You have a long, wonderful career ahead of you and you want to save your back. You do not want to injure your back. All right, I don't see questions on Unit 3. If you do have them, pop them up in there. I'm going to go ahead and move on to Unit 4. Unit 4, of course, related to GI and diabetes. So let's go back to the basics. Let's go back to, you know, promoting nutrition and promoting bowel elimination. So when you think about promoting nutrition, you want to make sure your patient has adequate calories. You want to make sure they have adequate protein, certainly your vitamins, your minerals. So you think about your choices. You're not, you know, they always say the more colorful a food is, the better it is for you. The more antioxidants, the more vitamins, the more minerals they have in there. So making sure they're getting adequate, you know, fruit and especially vegetables, that the proteins that they're choosing are, you know, your good proteins, your complete proteins. Also the fats that they're choosing, you know, lower in saturated fat, higher in your unsaturated fats, that are your healthy fats. So things to kind of think about there. Maximizing intake. You know, if you have somebody that has a decreased appetite, or perhaps they have had surgery on their bowel and they have a smaller length of a small intestine, because the small intestine is what absorbs your nutrients. Your GERD patients, they are going to benefit from smaller, more frequent meals. Okay, 1, from a symptom management perspective, but 2, to maximize their nutrition. If we're using supplements, oral supplements, things like Boost, Ensure, you know, going back to the old tip of having your patient, if they're in the hospital, a lot of times they're sitting in bed, they're watching TV, they're not doing a whole lot. If they're watching TV, every time the commercials come on, have them take a couple sips. Okay. Same thing with fluids. You know, right now we're talking about this with oral supplements, but this is good for fluids too. If you need to increase the fluid intake in your patient, that's a good way to get them to drink more frequently. And they're actually overall going to take in more supplement or more fluid than they would if you just gave them a large amount to drink at once, because they're going to get full. They're not going to finish it. But if they do a little bit along the way, that's going to be more beneficial to them. You know, other things with promoting nutrition and safety, you know, they're eating, make sure they're sitting up. If they have aspiration issues, this kind of ties in a little bit to Unit 6, but if they have issues with swallowing, thinking about those aspiration precautions, that they're sitting upright, ideally in a chair, if not all the way up in the bed, but ideally in the chair. The small bites, the no straws, the cued swallowing, the double swallow. So they swallow, wait a couple seconds, swallow again before they take that next bite of food. The chin to the chest swallowing to help facilitate that. So just kind of thinking about that piece. We talked a little bit about enteral feeding, but you hit most of that in foundations. But again, if you're taking care of a patient who's receiving enteral feeding, what are the critical pieces of that? Tube placement, verifying tube placement, verifying residual, and making sure you're giving them adequate water, because those feeding solutions tend to be very concentrated. And when you put that in there, if you're not using adequate water flush, that's going to cause water to shift into the bowel, stimulate peristalsis, and they're going to have diarrhea. So we think about fluid and electrolyte imbalance with that, as well as a nutritional piece. But also safety, you know, checking that tube placement, making sure the head of the bed is elevated at least 30 to 45 degrees with that, you know, because we don't want them refluxing, we don't want them aspirating. So just thinking about the safety piece with that. You know, promoting bowel elimination. I talked about this a little bit with urinary elimination before, but when you're promoting bowel elimination, the best time to try to get your patient to go is generally after the morning meal, because they've taken some drink in, they've taken some food in, it's stimulating peristalsis. So if you can get them to the commode, to the toilet in a sitting position after breakfast, that's going to best promote bowel evacuation. Obviously, a lot of our patients, or a lot of the disease processes we talked about this semester, impacted mobility, and we talked about decreased mobility quite a bit, and that's going to put your patient at risk for constipation. So thinking about non-pharmacological things that we can do first, because we always want to go least invasive to most invasive, increasing fluids, increasing the amount of fiber in their diet, because that's going to add bulk to the stool and stimulate peristalsis. Now, it is very important to understand you cannot add bulk, you cannot add fiber without adding fluid, okay? Otherwise, you can actually cause an obstruction. So those two things, the fiber and fluid, and then of course, increasing their activity as much as possible, because that's going to stimulate peristalsis as well. You know, so from a foundational standpoint, thinking about, you know, promoting that bowel elimination. You know, other things related to Unit 4, we talked about gastritis, and we worry about bleeding and hemorrhage with that. So certainly remembering the Fab4, your NSAIDs, your aspirin, your potassium, and your corticosteroids, your prednisone. Those are things that are going to predispose them to gastritis. So making sure they are taking those things with food. If they have a disorder such as GERD or gastritis, peptic ulcer disease, thinking about the medications, you know, your proton pump inhibitors, those are always important to take prior to meals to get the most effective, you know, benefit of it. Usually we say 30 to 60 minutes prior. Your H2 blockers, those can actually be taken with the meal. So that's important to kind of know, because we want to get the most bang for our buck out of the medication. You know, other things to kind of think about in relation to laxatives. And we didn't talk a whole lot about laxatives this semester. This was covered more in fundamentals, but again, we bring it forward. You know, we talked about non-pharmacological things, adding fiber and adding fluid to the diet. So if we're going to start adding a laxative in there, your safest one is really to start with the bulk forming laxative. You know, this is like your Metamucil, your Psyllium. Again, to add bulk, you have to add fluid when you're adding bulk, because we don't want, you know, any type of obstruction. Your other types of laxatives, you know, your Ducalox, your suppositories, your things like that, those are kind of the next step. We really wanted to try to address things with diet, you know, fluid, fiber, exercise, your bulk forming laxatives, stool softener, before we go to the point of stimulant laxatives and things like that, because they can become, your patients will become dependent on those. So we want to try to avoid that if at all possible. Let's see here. Colorectal cancer, we talked about, kind of ties in with Unit 6. Big things to think about is your change in bowel habits and, you know, your colonoscopy screening. Those are going to start for your general risk patients. Those are going to start at age 50, and they generally get repeated every 5 to 10 years, pending that they've had a normal colonoscopy. If they find something funny on it, they're going to repeat that more frequently. Let's see. All right, so Unit 4. All right, diabetes. Diabetes. I love diabetes. Okay, Not really, but it's a lot of fun. There's a lot of information you need to know about diabetes, but just stop and step back for a second and kind of think about it. You know, if you could only teach your patient, you know, 5 or 6 things about diabetes, what stuff is going to be the most critical? What do they need to know to be able to take care of themselves on a daily basis? And number one, they have to know how to check their blood sugar. So, you know, as a nurse, you need to know how to check their blood sugar. You need to know how to be able to teach them to check their blood sugar, and be able to interpret those findings. So, you know, we typically say if it's less than 70, it's considered hypoglycemia. So if they identify that, you know, either by the symptoms of hypoglycemia or by checking their sugar, you know, how do they respond? You know, the 4 ounces of orange juice, 4 ounces of apple juice. Essentially, you want something that's going to be about the equivalent of 15 grams of carbs, or 1 carb exchange serving, to be able to get that up there, and then rechecking their sugar. So, you know, that's key information that they need to know about. You know, they need to know some basics. If it's the first time I'm meeting them, I'm probably not going to get into a complete diet plan down to the, you know, how many servings, but they need to have a basic understanding of how diet influences blood sugar control, and how we think about, particularly for type 2 diabetes, because obesity is a huge risk factor for type 2 diabetes. We think about calorie control, because generally these patients need to lose some weight. So we want to, you know, control their carbs. We also want their carbs to be consistent throughout the day. So we're keeping their blood sugar nice and steady instead of having peaks and valleys. Okay. So some basic things about that, you know, thinking about complex carbohydrates are going to take longer for the body to break down as opposed to simple sugars. So if I'm talking about a sweet potato versus a regular potato, or I'm talking about a whole apple versus apple juice. Okay. So just kind of thinking about that, thinking about the consistent carbohydrates throughout the day. Understanding how exercise impacts the disease process. So certainly for type 2 diabetes, exercise is going to help promote weight loss. So that's going to help with their glucose control. But the other thing you want to keep in mind with exercise is that they shouldn't be exercising when they're sick or when their blood sugar is already extremely high, because it's going to actually make it go higher temporarily. And the other thing they need to be aware of, in particular for people who are type 1 or your type 2s who are also on insulin, is that as they're exercising, if they're exercising for a long period of time, or when they're done exercising, they're going to be at risk for a hypoglycemic episode. So they always want to carry a simple, fast-acting sugar with them. So they have it available to be able to treat hypoglycemia if it occurs. Okay. Other things that are really important for long-term management of diabetes is thinking about preventing complications. So obviously the best way to prevent complications of diabetes is going to be to control the blood sugar. We want that A1C below 7, 7 or below. That's where we want it to be. That indicates good glycemic control. So that's the best thing that they can do. But other things, just to kind of emphasize that, they can experience issues with their vision. So it's important for them to see, the ophthalmologist for the eye exam is recommended yearly. Thinking about their urinary health. Okay. So making sure they're maintaining hydration, especially if they're on medications such as metformin, because that does get metabolized and excreted through the kidneys. Certainly if they're on metformin, we've talked about this to death, the IV contrast. If they have an IV contrast study, that metformin has to be held for 48 hours afterwards. Sometimes we hold it longer depending on what their BUN creatinine, GFR is. Thinking about diabetic foot care. This was a big thing because diabetes does predispose them to neuropathy, and it increases the risk for infection. And if they get a wound or an infection, particularly on their lower extremity, a lot of times, it starts with the amputation of a toe and it keeps going. So that type of stuff is really important. So, well-fit shoes, making sure they're wearing light-colored socks, making sure they're inspecting their feet daily, they're washing their feet daily, again, patting dry. You can use the hair dryer on the cool setting. If they can't see the bottom of their feet, they need to put a mirror on the floor so they're able to move it around and be able to see their feet, inspecting that every day. Lotioning up their skin, particularly their feet, staying away from between the toes, letting that lotion dry before they put that sock back on. Always wearing footwear, you know, not going out walking barefoot at the beach, you know, swimming in the swimming pool. They really should have those water shoes when they're walking out there, because especially at the beach, you can burn yourself on the sand. Well, you can burn yourself on the sidewalk too at the pool. But in the sand, you know, there's little shells, different things that can, you know, cause microscopic or deep cuts in the feet. And then you're just looking at a big problem there. So, you know, when you think about diabetes, think about the big pieces. Diabetes is big, but if you break it down, you know, what are the basics? What does this patient need to know to be able to manage, you know, at least as a starting point? So, all right, that was a lot for Unit 4. So people have questions on Unit 4 at all? I don't see any questions on Unit 3 either, but if you have questions on Unit 4, go ahead and kind of throw them up there. We're going to move on to Unit 5, which that's been a little bit more recent, so that probably should be, you know, fairly fresh in your mind. But again, you know, go back to the basics with this. Go back to your basic concepts. It doesn't matter if we're talking about cystic fibrosis or if we're talking about, you know, chronic bronchitis or we're talking about a pneumonia. If they have sputum and it's causing an airway obstruction, you know, interventions to promote airway clearance are going to be the same. Okay, so things to kind of keep in mind with that. All the stuff we talked about, you know, certainly if they require suctioning, not that we got into suctioning a whole lot this semester, but understand that, you know, we'll use it to clear the airway. If we're doing, you know, deep suctioning where we're going down into the trachea, it is considered a sterile procedure, you know, from an infection control standpoint. But other things to help promote airway clearance, the coughing, particularly coughing after they've had a breathing treatment, taking some deep breaths and coughing, trying to, you know, maximize the effectiveness of that airway clearance. Hydration to thin the secretions. If they're thinner, it's easier to hack them up. Things such as chest physiotherapy, vibration, chest percussion, and drainage. That's all about loosening up that mucus so then they can cough it up. It all relates to that airway clearance. When we think about gas exchange, you know, putting oxygen on a patient, if I can maximize the oxygen that's getting down into the alveoli, I should theoretically have more that's going to go across the alveolar capillary membrane. Other things that are going to maximize gas exchange are going to be treating the underlying cause. You know, if I have a decrease in gas exchange because my patient has pneumonia and some of those alveoli are filled with fluid, exudate, you know, nastiness, white blood cells, pus, all that, I have to treat the underlying infection. If they're having impaired gas exchange because their fluid volume overloaded because they're in heart failure, I have to treat the underlying cause. I have to get rid of some of that extra fluid so I can improve gas exchange. So, you know, when you think about the respiratory component here, I really want you to think about it from those global perspectives. You know, if it's an infection, we have to treat the infection. We're treating the underlying cause. We talked a lot about medications. So your bronchodilators are going to help open up those airways. There's short acting and there's long acting. The corticosteroids are going to help decrease inflammation in the airways. So you have your inhaled corticosteroids. Usually those are either your meter dose inhalers or your dry powder. They do have some inhaled corticosteroid nebulizers as well. But those are more for your long-term control. And then you'll have the acute flare-ups. We'll treat them with the IV corticosteroid, the methylprednisolone, the solumedrol, or we'll treat them with PO prednisone. Okay, just to try to get them over that hump. Other things with, you know, promoting respiratory function. Think about the positioning of your patient. Generally, we want to sit them upright because that's going to allow for greater lung expansion. You know, something else to think about, I don't know how much you guys have been, you know, following the COVID in relation to the actual treatment protocols, and you will talk much more about this, you know, next semester, MedSurg 2, MedSurg 3. But one of the things that we're seeing in your very, very severe COVID patients is they've begun also positioning them prone on their abdomen, usually about 4 to 5 times a day. And with that repositioning, they're seeing that that seems to help a little bit with moving secretions and taking some of the workload off. So, you know, when we talk about positioning, you know, those patients are typically vented or on their way to almost being vented. But in general, for our more mild things, we want to definitely make sure we're sitting them upright. Help promote that lung expansion. That also helps just open up the airway too, if you have somebody who has diminished level of consciousness. You know, when we think about the cardiovascular piece of all of this, promoting circulation, because when you think about it, it all comes down to oxygenation and perfusion. You know, if there's not adequate oxygen in the blood, and that blood is not able to circulate to be able to take that oxygen and the glucose to the cells, the body will cease to function eventually. Those cells will not be able to function. They're going to go into anaerobic metabolism. They're going to create acidosis, and eventually we're going to get to death. So when you talk about a critical patient like that, you know, as somebody once said this to me, and it really rings true, especially with the COVID-19. When a patient dies, they die one cell at a time. So when you think about how we're going to save them in relation to oxygenation perfusion, we're saving them one cell at a time. We're really promoting that oxygenation and perfusion to the cells. So Unit 5 is critical with that. So thinking about promoting circulation, certainly we need to have adequate blood pressure. If it's too low, it's not going to circulate. If it's too high, it puts a lot of stress on the pump, on the heart, and the heart is not going to be able to pump effectively over time. So when you think about Unit 5 in relation to blood pressure, we talked a lot about hypertension. So think about the management of hypertension, both lifestyle, okay, so diet, we want to make sure they're having a low sodium diet or controlled sodium diet. Also, we don't want to completely limit their fluids, but those patients would probably not benefit from 3 liters a day either. So thinking about it that way, certainly weight loss is going to be helpful for that. And then of course, we talked about the antihypertensive medications. And again, there are lots and lots of antihypertensive meds. There's different classifications, your ACE inhibitors, your ARBs, your beta blockers, your calcium channel blockers. There's specific things with certain ones, okay? So just kind of think about antihypertensives in general. We're giving a medication that is going to alter this patient's blood pressure. What do we need to check before we give it, you know, or what do we need to be monitoring? If it is a medication that affects electrolyte levels, so certainly if it's a diuretic, thiazide diuretic, loop diuretic, it's going to lower the potassium. If it's potassium sparing, okay, obviously that's going to raise their potassium. Their ACE inhibitors, their angiotensin II receptor blockers, those tend to hold on to potassium as well. So again, we want to watch potassium with that. Your beta blockers, because of how they work, it's going to lower the heart rate. So that's something we want to be checking before we give that. Calcium channel blockers, as they lower the blood pressure, you can get reflex tachycardia and the heart rate can go up. So a lot of times if they're being treated with a calcium channel blocker, they're usually on a beta blocker as well, just to kind of manage that heart rate piece of it. Okay, so kind of think about those things. And as it drops their blood pressure, what are you concerned about? It's going to put them at risk for falls. Why? Because they have that orthostatic hypotension. So thinking about that piece, you know, it all goes back to that basic safe care, keeping your patients safe. You know, what do they need to know about the drug? What are the top 5 things? What are the key things they need to do to keep themselves safe? Okay. Let me check my notes here. Oh, ABGs. We haven't talked about the dreaded ABGs. Okay, so arterial blood gases. Definitely something you want to review. You know, at this point, at this level, you should be able to look at the ABG results and be able to interpret them. At least to be able to say, you know, is it respiratory, is it metabolic, is it acidosis, alkalosis? You also should be able to start, you know, to be able to determine compensation at this point, you know, and kind of think about these ABGs in relation to what the patient condition is. You know, so for example, we talked about diabetic ketoacidosis. So that is a metabolic acidosis. All right, so there's too much acid in the body. What is the body trying to do to get rid of it? Well, it's going to increase the respiratory rate and depth because I'm trying to blow off excess CO2 to balance that pH. Okay, so let me hit back to this. Do we need to know anything about DKA? You need to kind of know the basics of what it is, and you need to understand who's going to be at risk for it. You know, this is your type 1 diabetics, and it's usually because they have inadequate insulin. So it's either because they didn't take their insulin, or it may be because they have an illness and the insulin that they are taking just isn't enough to cover them, okay, because their metabolic needs are much higher. Okay. Trying to think anything else with Unit 5. That's a little bit more fresh, so that shouldn't be, you know, too far off in your brain. I think I hit the big points on that. Unit 6, that should be really fresh. So when we think about Unit 6, you know, we talked about stroke, and, you know, stroke, you have the emergent and you have the acute phase, that initial response to, oh my God, this person's having a stroke right now. You know, let's get them to the hospital. How do we diagnose them? How do we treat them? But then we switched in more to the rehab phase. And when we talked about that, and also the same with multiple sclerosis, myasthenia gravis, your Parkinson's disease, and to an extent, even your cancer, your chemotherapy patient in relation to the anemia and the fatigue that they have, those were all really focused on chronic management, okay? You know, so we go back to the concept of, you know, maximizing function of every body system and minimizing the complications. So a lot of the stuff that we talked about in Unit 1 in relation to the integumentary system also applies here. You know, the stuff that we talked about in Unit 6 related to nutrition and elimination is going to apply here. Same thing, Unit 3 with musculoskeletal. So you're using a lot of that information and those concepts in taking care of these patients with chronic neurological disorders. So just a couple things I kind of wanted to mention in that, that kind of go a little bit beyond that. Certainly the communication piece for our patients who have had a stroke. When they have problems with aphasia, whether it's expressive or receptive, and they have problems communicating, that can be very challenging. So, you know, when you talk to those patients, yes or no questions, closed-ended questions are very appropriate. And I know that goes against everything that we taught you, therapeutic communication. But in that particular instance, asking them to tell me how you're feeling, they can't put those words together. They might not be able to understand you. They definitely can't put those words together to articulate what it is they want to say. And that's going to be more upsetting and more frustrating to them. So for that type of patient, closed-ended questions are very appropriate. Same thing if I have a patient who presents with chest pain. Tell me about your pain. No. Do you have chest pain? Yes. Point to where your chest pain is. Is it radiating? Yes, no. You want to be very specific because you need some very rapid information to be able to respond. Okay. So, you know, that communication, I wanted to kind of emphasize that. The other piece I really wanted to emphasize too with that is, you know, alternate forms of communication. So, picture boards, common words like that are going to be very important. You also need to get the family involved too, because they need to know what to expect. It is not uncommon for stroke patients to, you know, just start laughing inappropriately. They may just burst into tears for no reason. And the family can often take that personally, feeling like they did something wrong or they did something that kind of brought that on, when really it's a symptom of the disease process. So they need to learn, you know, the family needs to understand that that is part of the disease process, you know, accept it, you know, kind of recognize it and you know, help them deal with that, but realize that it's not something that they're causing. And a great example of this is my dad. He's, one of the things that will literally set him into a crying episode, like he can be perfectly fine and he will just burst into tears, is hearing the national anthem. I'm not quite sure. I have some theories. I think it probably relates back to his previous military service, but if he hears the national anthem or somebody comes up and says, thank you for your service, he will just burst into tears. And you know, it's, of course, the person that said it then feels absolutely horrible because they made him cry. But the reality is they didn't do anything wrong. This is part of the disease process. It's part of how things, you know, neurons are not firing and processing in the brain because of those dead tissue areas. But that communication and family coping for any type of chronic issue. You know, we're talking about this from a neurological perspective, but you will have caregiver role strain and you will have difficult interrupted family processes with any type of chronic disease management. So it's just something to kind of think about and keep in your mind, that psychosocial support that we provide both to the patient and to the family. So I wanted to talk about that. Other things in relation to that, I wanted to hit on cancer a little bit. Overall, everybody did fairly well on the exam in relation to cancer. So I think you have a pretty good handle on that. It really does relate back to a lot of the same things that we talked about. You know, it's all about maximizing function and preventing complications. So with your cancer patient, where I wanted to hit a little bit more on is the pancytopenia. Anemia we kind of talked about in relation to unit 3. So certainly we want to maximize their nutrition. It is important that even though your chemotherapy patient is fatigued and tired, they are still engaging in at least some activity. That might be a short walk every day. Literally, that short walk could be from the bedroom to the kitchen. It might be from the front door out to the mailbox and back in. But we definitely don't want to go the other way, all the way to immobility, because then you have the risk factors for immobility, the DVT, the muscle wasting, and everything that kind of goes along with that. In relation to the thrombocytopenia, so this is the low platelets, your patient's going to be at higher risk for bleeding. So you want to think about interventions that are going to reduce the risk for bleeding. So an electric razor would definitely be advisable. Certainly we would want to avoid injections as much as possible. You know, we want to avoid IV sticks, other injections. Sub-Qs generally don't bleed as bad. IMs will definitely bleed if they are, you know, severely thrombocytopenic. But again, we want to try to avoid that trauma as much as possible. Where I really wanted to hit on was in relation to the neutropenia, the leukopenia. So this patient is at extreme risk for infection. So again, you know, it's relative on what their lab values are going to show. So you definitely want to relook at the lab values. You know, again, if things are slightly low, yes, they're at higher risk for infection. So we're going to be a little bit more careful, but we're not going to implement neutropenic precautions until their white count is generally below 2. Some facilities will actually say below 1. And when we talk about neutropenic precautions, this is where we have all the extra stuff. So everybody wears the gown, gloves, and mask. And again, it's not to protect us from the patient, it's to protect the patient from us. So it's a different scenario. If they're in the hospital, they really should be in a private room. You would not want to put them in a negative pressure room, however, because if you think back to the basics of infection control and airborne isolation, negative pressure, when I open the door, the air is going to go from outside the room to inside the room. I definitely do not want that for my patient who's immunocompromised. I want to keep the outside stuff out. So private room is okay, negative pressure is not. If they're at home, certainly you're going to minimize visitors. You don't want people in and out. So in the hospital, we would also limit visitors and minimize visitors. No fresh fruits or vegetables. Everything needs to be cooked thoroughly. We would be using bottled water. And even once the bottle's open, I wouldn't let it go more than, 2 to 3 hours and be replacing that, because when you have that stagnant water, you can have the growth of bacteria. They even have individually sliced and packaged bread for these patients. Just very, very meticulous with our infection control practices, excellent hand hygiene, sterile technique. Certainly changing out equipment. If any type of equipment is going to have moisture in it, oxygen tubing, nebulizer equipment, humidification, that all needs to be changed out daily. In general, that stuff gets changed out weekly for most patients in the hospital. These patients, it needs to be changed out daily. So those are some things to kind of think about in relation to that. When we talk about minimizing exposure, you think about, we want to essentially limit visitors, but we also don't want to, limit their overall well-being. So you have to kind of think about who would be appropriate visitors for this patient. Certainly, if anybody is showing signs of illness, they should not be visiting an immunocompromised patient. Absolutely not. But if you have somebody who themselves is immunocompromised, unless they have an active infection, they are not a threat to your neutropenic patient. I think there was one of the responses on the exam related to somebody that had a tuberculosis infection years ago. If it's not active TB, that patient is not at risk for transmitting it to anybody else. The one thing that we do tell people is vaccines, particularly the certain vaccines that are live virus vaccines, your MMR, your varicella in particular. Those are live attenuated vaccines, and people who get those can shed some of the viral particles. So it is generally advised for patients who are receiving chemotherapy to not be around people who have recently received vaccines. We kind of use that as a blanket statement. Your inactive vaccines generally aren't a problem. It's your live attenuated ones that can be an issue. So, little children who are usually full of bacteria and infection anyway, plus get all the little vaccines, probably not a good time to visit grandma when she's hitting her nadir. So just important things like that. Just a couple last things that I want to mention. And then, of course, if anybody has any other questions, go ahead and throw them in the group chat for stuff that I didn't hit. Two more things that I really want to mention, and we've kind of hit it heavy in the last couple weeks, is delegation. As an RN, you're going to be managing this patient's care, and you're going to be doing a lot of delegation. So understanding what is appropriate tasks that you can delegate to the LPN versus the unlicensed assistant, your AP. So again, I want to say it's page 27 in your ATI fundamentals book. You definitely want to take a look at that. But you also need to think about that in consideration of the appropriateness of the task. So for example, as I mentioned before, APs often calculate output, but if your patient had a CBI, that would generally not be appropriate to delegate, okay? If you have an unstable patient, they're circling the drain, you should really not be delegating vital signs to your AP. So just some things to kind of think about there. Prioritization, we've been doing this all semester. What is the nurse's priority? What action will the nurse take first? Which assessment finding requires immediate notification. So you've noticed this semester has been a lot about prioritization. The final exam will be a lot about prioritization. So I will do my last final plug for Nurse Logic and prioritization. Think about the things we talked about. What's going to kill your patient first? Which one of these things, if I don't do, is going to cause the most harm to my patient? Okay. If it's one of those, notify the provider. Which one of these things at 3 o'clock in the morning am I going to pick up the phone and call the provider about? All right. So think about those things. There is some dose calc on the final exam. For the most part, people were doing fairly well with that. I do want to hit on the last exam, people that missed the heparin infusion question, okay? With that particular question, the question before it talked about calculating the initial bolus dosage. Most people did not have an issue with that. The ones that did, again, they did not round the weight to the nearest 10 kilograms. On the infusion question, if you read it, it talked about 6 hours after the infusion was started, the PTT was blah, blah, blah. So what you needed to do there, it started, based on the protocol, it started at 18 units per kilogram per hour. What you needed to do 6 hours after was look at how you respond. So if it was, decreasing it by 2 units, I started at 18 units, now I'm at 16. Or if it's increased by 2 units, I started at 18, now it's at 20. Most people that got that incorrect did not decrease it from where it originally was. The math that they actually calculated out was correct. They just did not calculate, they didn't plug the right numbers into the formula. Or again, they didn't round the weight in the proper way. So just two things to kind of think about. You know, it kind of goes back. One last plug for Nurse Logic for the critically reading test items. Make sure as you are reading the test item, what is the question asking? What is the question asking? Because if you miss keywords in there, it leads you astray. So I think that is all I have. I did create the ATI custom practice assessments that I put up there. The Google Games are up there for units 5 and 6. I do not have them to be able to do for 3 and 4 and 1 and 2. And I'm probably not going to be able to do that prior to the exam. I can try to put up a couple, but I don't want to commit to that at this point because I do have a lot on my plate this week. In relation to that, I think the thing that is going to best help you though is looking at those ATI custom practice assessments, because they are going back into the NCLEX style question. There is a 24-hour lockout between those two, or between two attempts of the same ones. So what I will do, I see somebody popped over, can you unlock the rest of it? Let me run the reports today and kind of see. I'd like to see that everybody's at least taken them once before I unlock that. So I will look at that. At the very latest, I will unlock it tomorrow afternoon. But I really would like to see. It's not going to be the most beneficial for you if you're taking them back to back to back. Like if I take unit 1 now and I take unit 1 again in 5 minutes and again and again. So I would like to see that, you know, everybody, or at least a majority of the class, has gone on and taken them the first time around. Like I said, the latest I'll unlock them will be tomorrow afternoon. But, you know, if I can see that people have been making progress on that, you know, I can unlock that earlier. But that's kind of what I have. Last minute questions? Going once? Going twice? All right, well, happy Nurses Day. I know the topics is done. Some of you still have pharmacology, but remember, when you're focusing on pharm, you're still really focusing on med surg too, because those medications are used to treat a medical surgical problem. So don't try to look at them as separate, as in silos, because everything really does blend together. So, all right, I'm gonna go ahead and end this session, and it will be processed and uploaded on the class YouTube channel. And we will look forward to Friday. So enjoy the rest of your day. Take care.